can have Dr. Balbir Singh's talk next, which is there.
Sounds great. Thank you.
So we talking about calcium today evening, and if we look at meta-analysis of 7 trials, which was published in 2014 in Heart, we clearly see that the outcomes of calcified lesions who had severe calcium was worse or double MACE rates at 36 months after angioplasty. So 3 years MACE rates were almost double, including almost double deaths, double myocardial infarctions, and higher revascularizations. So this is 2014, and this should put many of us think that if we are doing the right strategy for our patients. But fortunately for us, Gary is here, and this is an ADAPT DS of his study, which said that increasing coronary calcium, they divided into 3 tiers: low, intermediate, and high. This is an IVUS sub-study. And they looked at the MACE results. And if the PCI is IVUS guided, there was no difference in the MACE. So increasing coronary calcium has been associated with complex procedures, higher difficulties with the procedure techniques, but it needs aggressive PCI techniques. And if you optimize your stent, you would get results equivalent to low calcium burden. So it makes life difficult for the operator at that particular point in time. But if you do a good job, have imaging to expand your stents, do an optimal job, you could get results which are similar to low calcium burden. So this refutes the previous trial or the meta-analysis, which suggested a double MACE rates. This is looking at calcium. This is a CT angio and can make things look really difficult. So we get very scared, but at least we know we are heading for some very complex case when you look at such images. Then looking at angiography, of course, should be the first starting point. Here you see a tram-like calcium. That you see this calcium on both sides. You see the calcium on one surface, the other surface, you see this calcium coming up in the circumflex. You clearly know this tram-like calcium is likely to go into severe calcium when you do imaging for this patient. Again, another case of a complex left main, and you see some calcium, but not too much calcium here. But however, we know angiography is insensitive. For example, this lesion did not suggest any calcium, but on IVUS, you see a long arc of about more than 180 degrees of calcium. So this is again Gary's paper in 1995, which suggested that angiography correlates poorly with IVUS detected calcium. So IVUS is far sensitive in looking at calcium. So intravascular imaging really helps to look at calcium. So IVUS is sensitive, but due to reflection of the calcium by the acoustic waves, it cannot go deep. For example, this is the calcium here. You can't go beyond that with this. OCT is not only sensitive, but also can measure the depth as well as the arc quite clearly. So this is a human coronary artery calcification as by OCT and histopathology. You can see this is the calcium and this is the calcium on OCT. Very good correlation. So the IVUS assessment is to look at the arc, the length, and whether it is superficial or deep. These are the 4 things that you want to know on IVUS. This is an IVUS image, and this is an OCT image of a different patient. So you see a full arc of calcium. After rotational atherectomy, you see the calcium reverberations do not help you to really assess whether you've done a good job or not. Then again, spotty calcium allows multiple vulnerable plaques form in between these spotty calcium, and they can present with unstable angina or ACS. Calcium nodule is another havoc for interventionists. This is what a calcium nodule looks on an angioscopy. It bulges into the lumen and creates a lot of problems. So if we compare the imaging techniques of coronary angiography, IVUS, and OCT, we realize OCT detection of coronary calcium is very sensitive, localizes quite well in terms of the arc and the thickness and quantification. So it does a little better job in terms of quantification, thickness, and the length than even IVUS does. So calcium nodule we're just discussing. This is how an OCT image of a calcium nodule appears like. It bulges out and then has all the properties of calcium, which Ziad just described. This is how it looks on IVUS. Let's look at one case. This looks like a very simple case. And when this was done, I thought it will be out in half an hour. But When balloon was passed, we had some difficulty in balloon crossing. So we took a smaller balloon, crossed it, and looked at the calcium. This is the OCT image, 360-degree arc of calcium, very thick. And look at this lumen, very narrow. So this is how the balloon inflated when we had to switch to OCT to look at what happens. This is a 2.5 balloon, and look at it, it's not expanded at all. This is the first thing one should look very carefully, an under-expanded balloon to guide you. This was a Wolverine cutting balloon, 3 millimeter, to cut through this lesion. And having done that, we assessed whether we have done something with that balloon or not. Yes, we had done 2 long cuts there. And this is the stent expansion, the same patient where a balloon was difficult to expand. We got an area of 8.27 in the distal RCA. Just tells us that how MACE rates can be reduced by doing this. We know the bigger the better concept. More expansion, the better outcome is going to be. Restenosis is going to be lower. So the best thing to do is assess your lesion before you decide what strategy you have to do. The IV intravascular imaging using OCT helps you to decide the arc, the length, and the thickness of the calcium. And a dog booning, which I showed you, also is a very good marker to tell you that you need to change. Suppose the score you get is less than 2, you could end up using a compliant or an NC balloon. But if score is 3 or more, maybe calcium modification using cutting balloons, scoring balloon, IVL, rotablator, depending on what you are comfortable with or what choices you have, would be very useful. So one of the best choices, if a patient can afford and you have, is to straight away go to an IVL if you have these markers there. If the IVL doesn't cross, you have rotational anthectomy, and this could be followed by an IVL and could be followed by a stent. Let's look at another example. This is angiographically tram calcium. You can clearly see the calcium. And this was a small 2.5 balloon to make us have an OCT run in this patient. And this is the OCT image. We go from the normal area, like Ziad was just mentioning, look at the distal landing zone, look at the calcium. Now look at the thickness, the arc of this calcium. This case cannot be done that easily. Now look at the length. Wherever you put the OCTs, you have the calcium. And then you have the proximal landing zone. Fortunately for us, beautiful landing zone. And this patient was treated with a 3.5 IVL balloons, got good cuts on this. The length was decided based on OCT, 2 stents. This is an IVL balloon opening up this lesion, following which 3.5 and 4 millimeter stents were deployed. And this is the final OCT run. Now, things do not happen. Even after IVL, after NC balloons, the expansion was 5.6 with 5.86 area. We weren't satisfied at all. We went further ahead with bigger balloons, 4 millimeter. Did get an expansion of about 75. That was the best that we got in this patient. So it tells us that, despite working so hard with multiple dilatations, with NC balloons, with OPN, with IVL, you sometimes do not get that 90% or 80% stent expansion in this. But the MSA was 7.4, which is quite adequate for this patient. This patient has done very well on a more than a year follow-up. And in summary, I would say that we have multiple modalities to look at the imaging, but doing complex coronary calcium lesions can be very difficult, may result in MACE. So we should use CT angio, angiography, IVUS, and finally OCT to help us see the distribution of plaque and help us manage our patients better. Thank you very much.